Apologies for the delay, transport problems.
Hi, good morning. May I call, please, Mr. Sean Holland?
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the
the
truth,
whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Sorry for keeping you waiting, Professor Holland. You probably travelled much further and got here quicker.
Delays are inevitable, I think, at this time of the year, my lady.
Mr. Holland, your full name, please.
Sean William Holland.
You were, during the pandemic, the Chief Social Work Officer in the Department of Health in Northern Ireland. Is that correct? Taking up that role, I think, in July 2010.
That's correct.
And moving on to Pastors New in October 2022.
Yes.
Just so that we can orientate ourselves in Northern Ireland and the position there, we know that it's the health and social care trusts who contract with the care home providers and indeed the domiciliary care agencies. Is that correct?
That is correct.
But as at the start and during the pandemic, I think there were 482 or 483 care homes in Northern Ireland. Numbers vary slightly. 16,000 beds. 93% occupancy rate within care homes in Northern Ireland, which I think is one of the highest across the UK. Would you mind just saying yes or no?
Yes.
Thank you. And I think there were something like nearly 21,500 individuals in receipt of domiciliary care and 300 domiciliary care agencies registered with the RQIA.
Yes, all of that's correct.
And I think in terms of workforce, as at March 2020, there were 36,855 social care workers who were registered.
Yes.
Can I ask you about the workforce, though, please, in the run-up to the pandemic? In your statement, which is INQ 613603, you make reference there, Mr. Holland, to a 2018 Department of Health report called the Health and Social Care Workforce Strategy. And that 2018 report outlined that there was an estimated 1,400 care workers needed every year to meet the growing demand on the adult social care sector. And the report noted that domiciliary care workforce needs and should be an early priority in recognition of the particular vulnerabilities we face in social care. Can you help us, Mr. Holland, with what was done to try and increase the numbers of workers in the domiciliary care workforce as a result of that 2018 report?
I think the demand for domiciliary care workers, it's helpful to understand there are a couple of different components to it. One is demographics, and I'm sure a lot of people would be aware that the demographic profile of the population is changing, and it's changing in that we have a growing population of older people. Within the population of older people, we have a growing number of people who are old people. That would be people over the age of 85, and they particularly drive demand because they're much more likely to have health and social care needs. The other aspect of the demographic challenges is that we have fewer young people, and so that's constricting workforce supply. There are fewer people in the labour market available for supply. And then the other side to the workforce challenge is that social care, particularly at the point of being a social care worker, a care assistant, or a domiciliary care worker, is a service that's largely delivered by the private sector, subject to market forces. And the market has settled at a place where those are often low wage, indeed minimum wage jobs, and zero contract hour jobs, which then leads to a churn within that workforce. So there are a few different elements, all of which combine to give a fragility to the social care workforce. In terms of what was done, each year the contracting of services would have tried to respond to the demand increase, and so that would be a case of we would find ourselves spending, trying to allocate more money, and sometimes that would be in-year monitoring money. Other times it would be more planned, but you were trying to expand the capacity through contracting services. But then we also took other actions to try and make the sector more appealing. So, for example, the department would have funded the Northern Ireland Social Care Council to promote the career and the sector as a rewarding place to work in. They also, again funded by the department, would have created employment frameworks which would outline how your career could develop within social care, and they also outlined practice learning requirements, a qualification framework. But all of those efforts are fundamentally challenged by the fact it still remained largely a very low-wage sector. That said, I'd have to say that that's a variable picture. There are some employers who do much better than others in terms of both being able to recruit and retain staff, and that's reflected. They tend to make decisions about taking a smaller profit margin, investing more in staff, that sort of thing.
And from the department's perspective, do you know whether the 1,400 estimate was actually met? Were we increasing by 1,000 care workers or only 500? Do you have any idea about how, if at all, the workforce was expanded to the estimated 1,400 care workers needed every year?
I don't have that information available to me at the moment, but we would have information about the registered numbers of social care workers, which broadly speaking has shown a trajectory of increase, and that increased dramatically during the later parts of, from the beginning of COVID. It was a very volatile figure, but it did increase. But there are limitations to that number, because that is a record of people who have joined the register.
Yeah.
People may join the register and you're registered for a period of 3 years, but then you may leave the job after 3 months.
Yeah, understood. All right. Do we take it, though, that as a general proposition, there was the fragility in the workforce entering the pandemic in sort of January, February and into March 2020?
There would have been a fragility in the workforce, and there would have been pressure on budgets, because the relationship is the budget buys the service, which drives the workforce, and there were pressures that were evident through a mixture of waiting times and thresholding of those services.
Can I ask you about one particular trust? And can I have up on screen, please, INQ 582 513_11. Mr. Holland, this is an extract from, I think, the the Northern Health and Social Care Trust. And can we see there that in January, the Trust's corporate risk relating to lack of capacity for domiciliary care was recorded as follows. The capacity of domiciliary care services, both trust and independent sector services, are unable to meet increasing demand. And it sets out there the implications of that. And at the bottom there of that italicised section, the risk has recently been exacerbated by independent sector providers handing back cases to the Trust to source alternative care provision. Two things about that, please. Was the department made aware of the fact that there were trusts out there that were struggling to meet increasing demand?
Yes.
And do you know, was this a position common across the other trusts, or was it particular to the Northern HSC Trust?
The position would vary in trusts, and indeed in some cases it would vary within different geographical sectors of trusts. So, for example, in the Western Trust, the area of what we would call Fermanagh and Lakelands, which is a very low population density, very rural area, would have had particular difficulties delivering domiciliary care services. Other areas wouldn't have had the same difficulty. So it was a problem across the sector. This quote specifically is looking at the capacity of domiciliary care, and it's important to draw a slight distinction here between different parts of the adult social care sector. So care home provision nearly exclusively, but not completely exclusively, has ended up and it was never the policy intention explicitly for this to happen, but it has ended up nearly exclusively being delivered by independent providers. Domiciliary care, about 70% of the services are provided by independent service providers, but there would be a capacity retained within all of the trusts for in-house domiciliary care. And so one of the actions that we were talking to the trusts about in relation to the issue of handbacks was expanding their in-house capacity.
Right. And does that then relate to the final paragraph on this italicised section? The risk has been exacerbated by independent sector providers handing back cases. We can't look after them in the independent sector, so the trust is going to have to meet their needs. Is that what that means, in short?
In short, yes, although it's slightly more nuanced in that you could have a provider saying we can't meet this need, and you might find another independent sector provider who could, but you would also be looking to your in-house provision. The net effect was that trusts were reporting a drift of complex high-need cases coming to their in-service provision. So independent sector providers, I mean, it's a pejorative phrase and it's one I wouldn't necessarily choose to use, but I would have trusts saying the independent sector are cherry-picking the cases that they want to deal with.
Right. I ask because obviously we're going to look in a moment at the discharge policy in March 2020, but does the department know how many or the proportion of patients that were discharged to care homes and those discharged to domiciliary care? We've heard in other countries it's a much higher proportion of discharged to domiciliary care. Was that the same in Northern Ireland?
I don't have the figure with me, but we would be able to access that.
Because the reason for asking about the lack of workforce in domiciliary care is if you're discharging many patients from hospitals into the domiciliary care sector, what steps were taken by the department to increase the capacity, given that there was going to be the expedited discharges?
A few things, and this is increasing the capacity, specifically the domiciliary care sector. Some of the measures applied to both the care sector and the domiciliary care sector. We sought to make it easier to recruit people. So we entered into a new arrangement in relation to police checks, pre-employment checks for care workers. Ordinarily, for care workers, you would have a check that encompassed two components. One would have been to check a barred list, because there are people who would be barred because of previous conduct from ever working in that sector. The other would be an enhanced disclosure check, which would be a more general check of police records. And for some posts, you could also consider non-adjudicated intelligence that the police may have held on someone. Now, what we said was that to speed up the process, we'll check the barred list. You can employ someone on the basis of them not being on the barred list, but there are conditions associated with what they can do. They have to be closely supervised. You will pursue the enhanced disclosure check, and you'll obtain that as soon as possible. But the safeguard being that you knew they weren't barred. So that was one step we took. Another step we took was, unlike situation, say, for example, in England, our social care workers are registered. So that's a statutory registration. It's not a voluntary scheme. There's legislation requiring it to be the case. And we have a workforce regulatory body, the Northern Ireland Social Care Council, who register as is common practice with registered professions. There's a fee associated with registration. Now, the Northern Ireland Social Care Council registers both social workers and social care workers. The fee is low for social care workers, it's £30. But recognising that people might join the workforce for a short period of time and then leave again, we suspended the collection of fees.
Waive the fee.
So that people weren't going to be put off by having to pay a fee. And then thirdly, we funded the NISC to increase their efforts to promote people coming into the sector to work. You
mentioned there the register, and I'll deal with it now, perhaps, if I may. we know that the Northern Ireland Social Care Council maintains the register, and it includes adult residential care workers, daycare workers, domiciliary care workers, supported living care workers. And you rightly drawn our attention to the fact that there is no such register in England. From your perspective, Mr. Holland, what were the benefits of having this register in Northern Ireland during the pandemic?
I think there are a few different benefits. Firstly, it gives you some, albeit slightly flawed, intelligence about the workforce. You know how many people at least are registered to work in social care, so that gives you that information. The other benefit, I think, is that it gives you some assurance, and it's probably particularly important if you're doing things like expanding the workforce rapidly under less than ideal conditions. It gives you some quality assurances because the registrants have some requirements placed on them. So they are expected to complete what we call PERTL, which is post-registration learning and training. They're meant to do 90 hours per registration period, which they're meant to document or be able to document that they've done 90 hours of training. It also means that they are subject to fitness to practice regulations. So if someone's conduct is such that it's deemed necessary or reaches a threshold for a fitness to practice, that takes you beyond the situation in England where...
Yeah, now can I pause you there? Yeah. Because I understand that that's a general benefit of the register, but what I was trying to ascertain was there any particular pandemic-related benefit?
We could communicate with the workforce. Yeah. So on a number of occasions, we both issued email messages and we also directed people through their accounts to social media messages that we were issuing in relation to the pandemic. And NISC also produced some very targeted learning resources for the workforce, which people would be able to access. The registrants would be alerted to, and they could access those. I think it was a suite of 4 learning packages. One related to infection prevention and control. Right. One was advice actually targeted to the general public about shielding and isolation. There was another package on resilience and emotional well-being, and I'm sorry I've forgotten what the 4th package was, but they were, I have to give credit to the Northern Ireland Social Care Council. They actually won a European Social Services Award for that suite of, and it was specifically for those COVID resources that they won the award for. But we were able to communicate and direct the workforce towards resources.
Thank you. Can I just take a step back then and ask you some questions, please, about surge planning? And in your statement, you say that the Chief Medical Officer commissioned work to quality assure and address gaps in the initial surge plans, recognising, obviously, that there were going to be pressures coming to both health and social care. And I think in your statement, you set out that there were gaps in the plans as far as adult social care was concerned. Obviously, the plans were predicated on staff absence being the most significant risk factor. Were there any other gaps identified in the plans as far as you were aware, Mr. Holland?
I think that the workforce was probably the main gap that we saw, but also there was a lack of account taken for the impact of mitigating measures. So the surge plans were initially developed on information that indicated that up to 80% of the population could fall ill. A proportion of those would require hospital accommodation. That would have an impact on the workforce. But and I think I'm right in this, that one of the things that we were concerned with was that the surge plans didn't take into account the potential impact of any measures that might have impacted on those figures.
Yep. Right. And can I just ask, ordinarily, surge plannings, is that something that should be done at trust level? Does the department ordinarily have oversight of the quality and content of the surge plans? Can you help us?
Normally, the equivalent, I would say, to surge planning would be winter pressure planning,
yep.
where and not unlike the pandemic, you have pressures arising from communicable illnesses circulating in the community. The trusts will produce their own individual winter pressures plans. The quality assurance and coordination of those would be done by the Health and Social Care Board, although they would then be shared with the department. But ordinarily, most of the activity would have been between board and trust in relation to that kind of planning activity. The responsibility in legislation for the board would have related to planning and commissioning services, whereas the primary responsibility of the department is about policy and legislation.
So it sits at sort of one level down from you, if I can put it like that. But can I ask you about, please, the mid-March plan? And could I have up on screen, please, INQ 103714_10. This was the initial, I think it was mid-March to mid-April plan, dated the 19th of March, Mr. Holland. It was a 12-page document, and in it, the plan predicted a 21% absence from the health and social care workforce. Appreciate, obviously, then there may be mitigations that might mean that there is fewer absences than had been predicted.
That would have been the case.
I understand that. But the discharge planning for patients in hospital is set out on screen. And clearly, they're talking about there the importance of discharge arrangements, the trust to activate their emergency discharge plans, reference there to expediting discharges, trusts working to maximise all spare capacity in residential nursing and domiciliary home care, and then potentially as a contingency plan needing to redistribute domiciliary care hours as is set out. And pages 10 to 11, if you forgive me for making the comment, don't actually mention very much the adult social care sector at all in this plan. Can you help with how practical or otherwise this plan was meant to be, knowing that there was likely to be a large number of people discharged from hospital in a relatively quick pace?
This set of actions, although you're looking at them in the context of a surge plan created during the pandemic, aren't that different from actions that would be undertaken each year in relation to winter pressures? I suppose the question was the degree of focus and energy placed into these different areas. But each year, part of the contingencies that you would adopt facing into winter pressures would include most of these. Some I don't think we'd activated before, so the choice protocols, although each year we talked about it, this was the first time we actively said no, people will be discharged regardless of first preference choice. But things like prioritising resources, maximising capacity, and speeding up discharge all were measures that would have been in previous plans. I think the important thing is that there was no change to the issue about medically fit for discharge, so that wasn't compromised. It was more about the processes associated. Discharge is always a point of pressure when the system's under pressure. And there's a tension between social care and the acute hospitals with, and apologies for characterising it in this way, you'll have the acute sector saying beds are being blocked because social care can't deliver, and you'll have social care saying patients are being delayed because the acute hospitals aren't operating effectively with their processes for discharge. And actually research has indicated that I think when people say, oh, it's a delayed discharge, it's a social care problem, normally 60% of the time it's actually relating to the processes in the hospital as opposed to in the social care sector. But what this plan is saying is make sure everyone's focused, everyone's working together, and that delays are minimised. It wasn't saying people should be discharged at a lower threshold.
No, and I understand that, but forgive me, looking at this plan, one might say it's rather generic and not hugely helpful to the trusts who are then having to try and find the spare capacity. Or can you help with, it's relatively high level, isn't it, Mr. Holland? And I just wonder how practically useful it was thought to be.
I think that there were processes happening at different parts of the system that would have different levels of granularity. So this is a high-level statement of what people should be doing. The how they're doing it would appear in processes at a lower level. I think it is also probably important to note that the capacity challenge that this anticipated was never realised. And the first quarter of 2020, although we were slightly up in the number of discharges into social care, it wasn't particularly high. And if you took as an average between the first and second quarter, we were quite significantly down in terms of the numbers of people being discharged into social care. I mean, there are a lot of reasons I could go into if you want for that, but maybe that's a later point.
Not right now, but I'm taking that as your point. But of course, you didn't know that as at the 19th of March when this discharge, when this guidance came out.
No, we didn't. This was in anticipation of pressures that never realised to the extent that we were preparing for.
All right. Now, in I think early August, the department established the Adult Social Care Surge Working Group. And I just would like to understand why it was established then and what practical benefits, if any, did it bring when we came into winter 2020 into 2021?
There was an evolution of various working arrangements from the very early days when the Chief Medical Officer initiated the Gold, Silver, Bronze Strategic Command response, where there were then a number of strategic cells incorporated within that, particularly focusing on things like infection prevention control, testing, at one point in vaccinations. But as we moved on, we recognised that while those had been an appropriate immediate response, we needed slightly different structures, and we decided that there should be a broader coming together of focus on social care. It's not that social care wasn't being considered, it was the framework that we were using to do it we felt evolved once we got through that first wave, and that's the structure that you're referring to. In terms of the benefit of it, it became where a number of different threads that might have been going through different cells were brought together and considered in relation to social care. It also was used to monitor progress against different initiatives or reports that were generated as we went through the pandemic. So, for example, there were two rapid learning initiatives, one in relation to nursing homes, the other in relation to domiciliary care. They made recommendations. That structure would have tracked progress against those recommendations. It also would have tracked other pieces of work in progress that were happening.
Can I come on to the discharge policy then? And we're familiar with the arguments for and against it and the pressures that were certainly predicted to exist at the time. In due course, I think there were various changes to testing regimes, pre-discharge. We may look at some of those in a moment. But in terms of isolation and the ability of care homes to isolate, I think certainly that there was care homes were not expected to have dedicated isolation facilities, but isolation precautions would be to be taken when someone was being discharged from a hospital into a care home. And certainly isolation requirements were approved by the Minister on the 24th of April. I'm at your paragraph 598, if it helps you, Mr. Holland, and communicated to the sector at the end of April. Can I ask you this firstly? Do you know why there wasn't a requirement put in place for isolation prior to the end of April 2020?
I think this was a developing scenario, and there were a number of points at which we adopted positions which were changes from previous positions. And I think in almost every instance, and again, I'm probably echoing the comments of my counterpart in Wales, it would have been better if these were done at an earlier stage than they were. But it was the progress under pressure with resources that there was always a lag to some of these things. Sorry, I'm not sure. Did you ask me something else in that question?
No. It was why it hadn't come in before. And effectively you said, well, with hindsight now, I think in short you're saying you wish it had, but...
Yeah,
things
and
developed.
I'd also need to reference it against the infection prevention control advice that was coming from the Public Health Agency, because that changed a number of times as we went through.
You do say, however, in your statement, though, that the department worked closely with the RQIA to assess the ability of different care homes to implement isolation policies. And indeed, it was noted that a small number of homes still use some double occupancy rooms. Does the department know how many care homes there were that were still had a double occupancy room?
We may have that information, but I don't have it to call to memory.
And I think certainly some care homes were assessed by the RQIA as not being able to appropriately isolate individuals because of the configuration of the care home itself. It was considered to be a very small number of homes that wouldn't be able to isolate. Discharges to those homes at the RQIA should not take place from hospital. But was there a ban, do you know, as far as the department was concerned, in saying, well, if you can't isolate, you must not accept them? Or did it not work like that, Mr. Holland?
No, the guidance issued was quite clear to say that if a care home couldn't appropriately accommodate someone and isolate someone and discharge, alternative arrangements would be made. And that was also the case when it came to the point when people were being tested. If a test result wasn't known, alternative accommodation could be arranged. And that would have been in a step-down facility. There were a number of step-down arrangements, and there would have been some step-down facilities that preceded the pandemic, and they would have been used under those circumstances. But at no time were we seeking people to accommodate people that they couldn't accept within the extant guidance.
Right.
And that is relevant to the previous point about the fact that we never faced the capacity pressures that we had anticipated as well.
I ask you that because I think there was a Northern Ireland Assembly Committee for the Health Inquiry report from April 2021, and in the findings of that report, the committee noted that many homes struggle to isolate individuals either for reasons of facilities or adequate staff resources, or equally importantly, residents' well-being and issues of understanding amongst the significant numbers of residents with cognitive decline who presumably weren't able to isolate themselves. And the department noted this was an area of policy the department continued to keep under active consideration. In what way did the department keep under active consideration the ability or otherwise for a care home to isolate individuals?
Well, one of the things we did do is when we heard suggestions that people maybe had to do something that they felt was out with the arrangements, was we tried to pursue actual cases to find evidence of them, and this was true in relation to a number of things. Would have included, for example, PPE. At one stage, the Independent Healthcare Providers Association were saying to us, a number of homes aren't receiving PPE. We asked for a list of those homes and followed them up, and when we did, we found that they actually were reporting that they received PPE. So that would have been one response. The other response would have been developing guidance to support care homes on an ongoing basis around the requirements for isolation and compliance with it.
And are you able to give us a practical example of the guidance that supported the care homes around requirements for isolation?
I'm trying to recall, I think the PHA probably issued guidance at some points. We included it in the departmental guidance. We also would have been providing advice and support to care homes on an individual basis about how they could meet those requirements through the service support team that we established, and I'm assuming you might want to talk about that at a later point. That was the repurposing of the RQIA staff, and we also gave them links with the PHA, who would have provided direct advice to them on infection prevention and control, including isolation.
Can I ask you to turn up perhaps in your statement, paragraphs 624 onwards, just sticking with the issue of isolation, because the RQIA did an assessment of care homes' ability to provide isolation facilities. And I think the result was that there was about 80 care homes that were available and able to isolate. I don't want us to misunderstand the figures, and there was various ways that the RQIA worked it out, but if there's 480 odd care homes across Northern Ireland, but only 80 of which could isolate, there's potentially quite a large disconnect there, and a large number of homes that were physically unable to isolate, notwithstanding the importance of it by end of April when it was written into the guidance. Do you know why that number is so low, and does it cause you any concern on behalf of the department, Mr. Holland?
I think this exercise needs to be put into context. This wasn't the RQIA going out and inspecting homes and looking at them and saying, oh, this home could only isolate 3 people, or this home couldn't isolate anyone at all. This was a desktop exercise that was only ever meant to be used at a system level. So they were simply reviewing things like, what was the home registered for, how many single-use bedrooms did they have, how many of them were en suite, and they were coming up with an estimate. This wouldn't be a document that would have been used to guide individual decisions to discharge a person into a care home. They would have been done on a case-by-case basis, and the two sides of the equation would have been the medical side, fitness to discharge, and on the care home side, ability to accommodate in line with the guidance. And there would have been a fluidity to that that wouldn't be reflected in this exercise. So, for example, you might have had a much lower level of occupancy in the care home for a variety of reasons, and there was a decline in occupancy in care homes through this period, which would have enabled them to enact isolation that wouldn't have been obvious from the desktop exercise that the RQIA had done.
So if I understand you correctly, the desktop exercise may in fact be an underestimate of the number of homes.
I would imagine it is.
Right. Put that figure to one side, one can foresee that in a future pandemic, the need for isolation may be particularly uppermost now in people's minds if there's delays to testing capacity and the like. Does the department know now, or has it asked for there to be any work done to actually ascertain which care homes could isolate an individual in their own home with en-suite facilities for 14 days, as was envisaged by the guidance?
I'd have to note that I'm coming up on 3 years from having left the department, so I can't really give an up-to-date position on the department. But a few points I would make, and you may come on to data at a later point. I think that while we did hold information on social care at the point of the beginning of the pandemic, we very rapidly evolved a far more detailed level of data collection, both in terms of what we were getting information on and the time frame within which we were getting it. I think that's a point for future learning, that we should make sure we have that data or better data available on the sector. The second point is, I think that isolation is something that probably should be thought about in a much more anticipatory way in terms of pre-pandemic planning for a future pandemic. And that then takes you to looking at the actual configuration of care homes. I think that building of care homes over the years has always been subject to standards, but those may benefit from being revisited to consider how the infrastructure would support a positive response to a future pandemic. And I mean, an example of this, and it's a tension that's been there before, would be there's been a movement over the past 20, 30 years to try and make care homes as homely an environment as possible. And sometimes that creates a tension with IPC requirements. So I remember at the beginning of my career, if I went into a facility like a care home, they all would have had lino floors. And over the years, there's been a dynamic between trying to create a more caring, homely environment and one that's suitable for IPC. Now, isolation is probably one of the areas where the two coincide, because I think increase in single occupancy rooms is something that both sides of that argument would have agreed to. But there are other elements like considering airflow and ventilation. I don't think that.
So can I ask you about that? You argue there quite strongly for more work to be done and to think about this pre-pandemic. Is that something that sits at the department's level, with the RQIA, with the PHA? Who is it that would be responsible for trying to ensure that some thought more thought had been given to the need to isolate?
I think giving more thought to it probably rests across a number of bodies. So the PHA would be the experts in disease transmission and infection and prevention control. The department would be the source of the standards and regulations that would determine eligibility for registration. So those two would need to come together. I also think that you need to engage the actual sector in that discussion as well, and recognise that care homes is a very generic term, and it's probably not doing a service to the diversity of needs which are met by care homes. There are care homes which are homes for life for people for a long period of time. There are places where people with physical disabilities and learning disabilities may live for decades. And I think that the consideration as to how you would build and configure something like that are different to the types of homes that are receiving very frail elderly people whose expectancy of residency is much shorter because they're at a different life stage. And I think that you would need to have very close engagement with the sector to make sure that you had differentiated standards reflecting the different needs and requirements. But certainly for those people who I think on the back of the experience of this pandemic we really know will be particularly vulnerable, there are things about building control regulations and maybe even size of facility that are going to be relevant. I mean, size of facility is probably
I'm going to come on to size. All right. Can I just finally, dealing with isolation, you say in your statement that the 14-day isolation did have an impact on discharge and patient flow. However, the department does not hold specific information regarding acute discharge delays. Can you just help us? Are we there saying that actually it did inhibit and delay the output of patients by the need to isolate them for 14 days?
Yes, I'm sure it did, because inevitably you will have had occasions where people were medically fit for discharge, and sourcing a bed that could accommodate them appropriately would take, it wouldn't instantly be available. I'd have to say that is not an uncommon problem. I mean, that is one of the challenges in normal times for discharge. You're relying on a turnover and a churn in beds, so there's sometimes a delay while you have to wait for the suitable placement for the needs of an individual.
Can I ask you about a different aspect of the discharge policy, and I think position in relation to residents with dementia? I think prior to the pandemic, residents with dementia could only be placed in a dementia-registered bed, but that on the 18th of March in 2020, the Health and Social Care Board confirmed they were content, if necessary, dementia patients could be placed in beds registered for other purposes. And there were various conditions put on that if a dementia patient was going into a non-dementia registered bed. Does the department know how many individuals with dementia were affected by this decision and sent to non-dementia registered beds?
I don't have that information, but I would refer you to the statements that have been submitted to the inquiry from the trusts,
yes,
who have indicated that this wasn't a facility that was significantly used. I could elaborate a little bit about this if it's helpful.
I can help you to this extent. Certainly we have a statement from the Belfast Health and Social Care Trust who said that change in policy had a limited impact on discharges because it was dependent on the care home being agreeable to take
Yes.
the dementia patient, and indeed it was met with resistance from the care home.
And I think a similar point was made by either the Southern Trust or the Southeastern Trust. And the informal feedback I was receiving was that this wasn't having any impact on increasing supply because it was dependent on, and quite rightly, dependent on the care home agreeing. Because we were setting out conditions that had to be met if you were to do this. And if a care home was saying, well, we can't meet these conditions, they were absolutely right to then refuse that discharge.
I think that change in the policy was not rescinded until the 10th of September 2021. Do you know why the policy was in place for such a long time, particularly if it wasn't in fact being really taken up?
I think pressures on the system were an issue through that period, which is why it wouldn't have been rescinded, although it wasn't having a significant impact. And when it was rescinded, I have to be frank about this, I think it was based on the fact that there had been a change in the, rescinded is the wrong way of putting it, and I think we use that language, so I apologise for that.
That's all right.
But the RQIA, there'd been a change in personnel at the RQIA, and when we were seeking to renew this provision, they said, actually, we think that in terms of our standards, you don't have that flexibility. Previously, they'd been happy to accommodate that flexibility. I think they were saying, now we're not so sure we have that flexibility. So although we describe it as being rescinded, what we actually said was, if you're going to do this, you need to get a temporary variation in your registration from the RQIA. But I don't think that was ever sought then subsequently.
Can I just stand back a little and ask you, please, about the Herity report that was conducted? It might be easy if I call up on screen an actual paragraph in your statement, Mr. Holland. Could I have up on screen 613-603_194 and paragraph 655? The Herity report, I think, came out in November 2020. And the links or otherwise between discharges and outbreaks in care homes was one of the matters that Dr. Herity, I think, looked at. And we can see there that the study examined 2 specific weeks in 2020, week 11, which started the 8th of March, and week 13, which started the 22nd of March, where the number of people discharged to care homes after an unscheduled hospital admission was slightly higher than the typical week. 465 patients were discharged to care homes in those 2 weeks. 5 people tested positive within 2 weeks of discharge and 460 did not. It did not support the hypothesis that this group of people was a substantial cause of COVID-19 outbreaks in care homes. Now, I think it's right that certainly there was no discharge in testing in week 11, but the first interim protocol on testing came out just before the week 13 testing. So clearly we need to bear in mind there was limited testing capacity at this time. Do you know whether the department did any other work to try and establish whether there was a link between discharges and the seeding of infection in care homes once testing was up and running?
I'm not aware specifically of additional work that the department did. The decision to discharge people at a point before testing would have been informed by the existing advice from the PHA and other experts at the time, and that's not part of my professional competence. This report, I suppose it's a point I would make about a few different sources. A number of reports have looked at this.
Yes.
I think there's been the Vivaldi study, there's also been studies in Scotland and Wales, and they've all concluded more or less the same thing. Now, I'm not a scientist and I'm not qualified to adjudicate the merits of each of those reports, but in a sense, these are all post hoc. They're useful in terms of contributing to our knowledge for how we might respond to a future pandemic. And actually, I think that's, if I was to ask you to do something, I think one of the things that would be that we would invest a lot more in researching, understanding about the differences that occurred between countries, and regions and services. I mean, currently we know, and please when I say this, this is not in any way to minimise the experience of people who died in care homes in Northern Ireland, and it's not to suggest anything positive about the system. We know that you were least likely to die in a care home in Northern Ireland compared to England, Scotland or Wales. Compared to England by quite a margin. Many European countries did much better than Northern Ireland, so it's not a point. But one thing I think for future learning is we need to understand that better, because currently we don't really know why. I mean, there are hypotheses about it, but we don't really understand that. Was it just purely about community transmission levels being different in countries, or was it that the infrastructure of the systems was different in countries, or was it individual COVID-specific interventions had an impact? And I think that's something that's really important. And this falls into that. It's after the fact. The point at which the people were being discharged, we didn't have this information.
Just picking up on that point then, you are not the first, and I dare say you may not be the last witness to suggest there should be more work done in this area. Do you know whether any work is being undertaken in Northern Ireland to understand how the infections get into the care homes, whether it's the community transmission? And if you don't know, who, in your opinion, would be the right body, organisation, department to further that research?
I don't know currently. I think that there are a range of bodies ranging from academic institutions through to government ALBs who have a role in commissioning, conducting and funding research. I think at a governmental level you can set a priority, particularly with funding bodies, to direct future research. And I really think that this is an area that merits that focus, because there were quite significant differences, and we don't properly understand why.
Well, perhaps can we have a look at some work that was done in relation to characteristics of a home that was affected by an outbreak? And could I have up on screen, please, INQ 103683_7. This is an RQIA document, Mr. Holland, I think dated May 2020. And they looked at some of the care homes that had outbreaks and then came up with these 6 characteristics, but it might require a little bit of elucidation through you if you're able to. Clearly, I think the suggestion is that homes run by a larger provider had more outbreaks. That's how I read it. Am I right in that? With 50% plus homes affected by COVID-19 outbreaks. A larger provider, can you give us an idea of what is a larger provider? 10 beds, 20 beds, 100 beds?
50 beds,
50
beds. What was being used.
Right.
I mean, this piece of work was as a result of a conversation I had with the then interim chief executive of the RQIA, Dermot Parsons. And, I mean, at an early point, we were looking for any source of information that might be of assistance. And so I just contacted Dermot and said, listen, maybe you're already doing this, or maybe it's not valid because I've no scientific expertise, but I said, might there be benefit in looking at the intelligence that you hold on care homes and seeing if you can find any correlation with either outbreaks or how well or otherwise they cope with outbreaks. And so they did this piece of work. It's not research standard. I mean, it was really, and I think the RQIA produced a leaflet and they make the point, correlation isn't the same thing. And I mean, you shouldn't use correlation purely as a way to target individual intervention. But it was just a thought to say, well, from what you know, can you link anything? Can you learn anything? And so that's what they came up with.
Right. So if the home was run by a larger provider, then they were potentially more likely to have had an outbreak. If the service had 2 manager changes, is this presumably care homes again?
Yes.
And so if the manager changed twice, they were more likely to have an outbreak. And does the department have any observations on why the managerial changes has maybe led to a link in increased outbreaks?
This would echo with some work I was aware of pre-pandemic. I think John Kennedy did some work for the Residential Care Forum in England, which was looking at, and obviously he wasn't looking at COVID at that stage, he was looking at regulatory failure and trying to identify factors that were indicators of an increased likelihood of regulatory failure. And I think he pointed to frequent changes of manager. I think the understanding is that leadership is very, very important, and that if you have frequent changes in leadership, it's a discontinuity in leadership, but it may also reflect good leaders not wanting to stay and work in a particular place.
And just briefly then, characteristics 3, 4, 5 and 6. Clearly, larger homes with 40 plus registered beds were more...
Sorry, I said 50 plus.
You did. It's all right, don't worry. 40 plus, more likely to have an outbreak. We've heard other evidence that, I think from Scotland, where a similar finding was. Less than 10 years since the first registration, what was the thinking as to why, if they had not been if they'd been registered in the last 10 years, they were more likely to have an outbreak? Am I reading that the right way round?
Yes, I think you are, and I never really understood why there would be a correlation there, but that's what Dermot came up with.
All right. And are you able to help us with characteristic 5, more than 10 requirements and recommendations? Is that they were required to improve by the RQIA?
That would reflect the level of previous regulatory direction they'd received. Now, it's important to say that doesn't mean that they had necessarily been subject to enforcement notices, but they may have been noted having areas of improvement. And I suppose that isn't surprising.
And characteristic 6, high-risk local government district defined as over 60% of nursing homes affected. Can you help?
That's community transmission.
Right, thank you. So there are potentially some ways which might explain why there were outbreaks in some care homes and not others. You mentioned a moment ago Vivaldi, and we know that Vivaldi found that the use of bank staff in particular was a risk factor. And Vivaldi came out in July 2020, I believe. Do you know what was done to restrict staff movement or the use of bank or agency staff prior to Vivaldi? And then again, what was done post-Vivaldi?
I think we had identified the use of bank staff and agency staff at an early stage in the guidance that we issued that predated Vivaldi. So we, from very early on, we were saying that you should minimise staff movement because it's a logic that footfall of any description. We'd already modified the RQIA inspection methodology to reduce footfall. So recognising that having large numbers of people going into a home who may work in other places, it was something that we recognised. So from early on, we'd recommended minimising the use of bank and agency staff. I think we also gave within the financial packages the flexibility and suggested that care homes use some of the financial support that we were providing to book agency staff, so that agency staff were being paid to go to them, and they knew they could rely that would be paid to go to them rather than going to multiple providers. Post Vivaldi, I think it was a case of really just it was a continued area of emphasis. So subsequently, the PHA at a later point after Vivaldi, I think it was quite a bit after Vivaldi, issued a leaflet which was specifically about highlighting the risks of bank and agency staff, but that was, I think, from the very beginning, something that we were emphasising in our guidance to care homes. Yeah,
you're right. The March guidance said that the homes should seek to limit turnover in staff they use and seek to limit the number of staff moving between different homes. A relatively uncontroversial but high-level statement. But given that there was the workforce shortages that we discussed, how realistic was it in the department's view to have fewer staff available because of, A, you're going in without a strong workforce, B, you've now got ill staff and or those who are isolating, and now you're telling care homes to restrict staff movement? One might be forgiven for thinking that those things don't sit very comfortably together. And so how was the care home going to limit the number of staff if they didn't have enough staff in the first place?
That's why we didn't issue a direction saying don't do it.
Right.
What we did was say you should strive to avoid doing this. And I think as we went through, guidance became more granular, and it was saying, go through these steps before you look to engage agency or bank staff. So look at how you can manage your rotas, look at how you can cohort staff to particular units, but we recognise the tension that you're highlighting.
Yeah.
And so I suppose the balance was that you have the potential risk materialising from bringing someone from one setting in to another setting versus the immediate risk materialising of not being able to provide the care someone needs at that point in time. And that's why it was about saying, try very hard, make this your last resort, but we never said you can't do it.
Can I, you mentioned there a one-page document. Can I have up on screen, please, 508 442? This was the document which we think was published in January, according to your statement, although it may have been actually written in November 2020.
Over the weekend, I've been trying to track down the exact date, and I've come up with both of those dates, and I can't stand over which one was the actual date it was published.
Well, it's not going to stop me asking this question, but if Vivaldi came out in July 2020, whether it's November or January 2021, certainly a number of core participants think that this guidance came out too late, given the importance of Vivaldi findings from the summer of 2020. Do you know why there wasn't guidance put out before either November 2020 or January 2021?
Well, there was guidance put out, but this is the PHA guidance. So, I mean, in every iteration of our guidance, I think we're emphasising the importance of minimising movement of staff. So there was guidance put out. I can't answer for the PHA as to why they put this out at that point in time.
We can see there from the PHA document, agency staff must not work in more than one setting on the same day. Agency staff should choose to work in either a hospital setting or a community setting and not both. But do I understand it from you that this is not mandatory?
Well, there's no...
Well, there's no sanction if you don't do it. No. A better way of putting it.
Yeah.
Right. And just more generally on the topic of limiting staff movement, did the department put in place any funds or measures to try and recompense staff who could only now work in one setting or now had to do limited hours? We're aware of the Infection Control Fund in England, but was there any similar funding put in place in Northern Ireland that was ring-fenced for this?
The block booking, we specifically said that you can block book staff.
One other matter in relation to limiting staff movement, was any thought given in Northern Ireland to bringing in legislation to mandate staff not being able to move between care home settings?
I don't recall it being an issue. I think before we got to the point where we might have thought about legislation, we were recognising this is a system that is fragile, and as with a number of things with the care home sectors, we thought encouragement, education, support, advice was better than direction and legislation.
And do you know if there's any thought being given to whether there should be legislation in the event of a future pandemic?
I don't have that information.
All right. You mentioned there perhaps potentially some cohorting of staff, and I think trusts were asked in October 2020 to consider how to cohort staff to limit the risks of infections. And there was a meeting, I think you say in your statement at paragraph 369, that on the 16th of October there was a meeting. During that meeting it was confirmed that working in one care home was not always an option for agency staff, as they were trying to assist shortages throughout all homes and trusts. Did the department do anything to try and encourage cohorting, either by way of funding, additional guidance, or anything of that nature?
I keep coming back to the block booking. That is a form of cohorting, and so that's what we were doing. And then the advice that I've referred to previously. but nothing in addition to those things.
And in relation to funding, I think financial support was provided in April 2020, June 2020 and October 2020. And there was various different funds then in 21 and into 22. The department became aware of some instances where care home staff refused to take a COVID test. Can you help us about that, Mr. Holland? Do you have any idea about the scale of that problem, the numbers, where this was happening, when it was happening?
I think we do have numbers on the uptake of vaccines by different occupational group and setting. I can't recall them.
Oh, that's vaccines, but I was talking about
testing.
staff. Yes, testing.
No, I don't think we've got the information on testing. I don't think that was collected. Sorry, your original question?
No, it's all right. Let me help you. You were aware of the problem of some instances where care home staff were refusing to take a test. You've not been able to give us any detail about the scale of that, but I think the department understood that part of the reason for refusing to take a test was because staff would have to rely on statutory sick pay. Does that ring?
Oh yeah, no, that's absolutely the case. We were, it wasn't simply the issue of taking a test. It was that people might turn up, even before I think that testing would have been available, that they might turn up for work when they were feeling unwell. So very early on we said that we would fund an increase of people's salary from statutory sick pay up to 60% of their salary. And that we just didn't want people... testing probably became relevant to that later, but it was before then, before the testing issue. It was just we didn't want people who were symptomatic coming into work because they were worried about losing their pay.
And so the department put in place some measures, I think, to fund independent sector employees up to 80% of the salary, including those on 0 hours. So there was some financial recompense if the staff member had to stay at home.
And that was also, I think, extended to staff who were shielding, and I think to staff who might have been pregnant, because there was early advice, I think, about members of the workforce who were pregnant being kept away from face-to-face practice, I think.
Can I turn to IPC as one of the other measures and ways in which to try and keep residents and indeed people living in domiciliary care safe? And I think, I know that the guidance was primarily led by Public Health Agency, understood. But one of the things that the department did explore was what was called the Safe at Home model. And can I ask you about that, please? I think the department explored the possibility of staff living in care homes for 7 days on, 7 days off, with an isolation period of 48 hours before they started the 7-day shift. Can you help with what was the rationale and the thinking between exploring this model?
There were two sources of rationale, I suppose. One was there were people talking about putting a ring of steel or a protective ring around care homes, and they weren't defining what that meant. And then I was also aware, a lot of people were aware, but that there were reports in the media of some homes where on a voluntary basis staff had chosen to move in and they seemed to be doing better at avoiding outbreaks. Particularly there was a home, I think it was called White House, in Tynemouth, in Devon. Well, I mentioned it because we were able to look at that as being a starting point. And so we just thought, well, would this work? And so we did some work to develop a proposal. We did a very quick high-level outline about how you might do this, having staff living in, enhanced testing, and what have you. We circulated it and got the views of Chief Medical Officer, Chief Nursing Officer. I'm not sure if the Chief Scientific Officer was there at that stage, but we circulated it round. And I think the view back was it was worth a look at.
Yeah.
So we then moved into trying to develop it in a more practical basis. Conversations were opened up with Four Seasons, as was. Carol Cousins would have been the regional director. We had a very good relationship with Carol. We would have consulted with her a lot.
I think, though, that in due course, notwithstanding the conversations that were going on with Four Seasons to potentially pilot the Safe at Home model, there was concerns raised by the unions about the supply of and guidance on PPE, particularly whether staff might feel compelled to live in.
Yeah.
And the unions were not supportive of the Safe at Home model.
No, we got to the stage with Four Seasons of identifying 2 potential pilot sites. Then they received communication from the trade unions and the RCN, where those points that you've just referenced were raised. There was a meeting held with the unions. The department tried to address their concerns. They were concerned, I think, about recompense. They were concerned about being pressured, as you say. And we made it absolutely clear, no, this would be an entirely voluntary scheme. No one would lose out financially if they chose not to participate. We went through testing and PPE and tried to address their concerns. But subsequent to that meeting, Four Seasons came back to us and said the unions still are not convinced, we can't proceed with that.
All right, and I think in due course, you and the Chief Nursing Officer issued a letter inviting expressions of interest wider than Four Seasons, but received no positive response.
Well, basically, we just went out to the sector and said, listen, if anyone is interested, we will work with you to try and implement this model.
Yeah.
And no one came forward.
No.
I'd have to say, looking back, it was not something that we ever could have ramped up to scale.
No.
But it was
Presumably because there wouldn't be enough staff who would want to sleep in for
a
7
whole
days
range
on.
of factors. I mean, you know, the layout of care homes where, you know, I mean, it just wouldn't have been something. But we did think it might have been worth to run a pilot just to see if there were elements of it that could have been transferred to the wider sector.
Do I take it then that, do you know whether there is any future plans to try and do a pilot like this, perhaps in peacetime, or to see if there's any merit in the Safe at Home model being rolled out and if needed in future?
I'm not aware of any plans in relation to that.
My lady, I'm moving on to a slightly different topic. Would that be a convenient moment for a mid-morning break?
Certainly. I shall return. I'm going to go by the internet time rather than the clocks. I shall return at past.
Thank you.
All right.
Kerry.
Thank you, my lady. Mr. Holland, can I ask you please about PPE? And when looking at all the documents and reading your statement, would you agree with this general proposition that the problems with access to PPE were most acute in March into April 2020, but thereafter, thankfully, access to PPE supplies generally began to resolve?
Yes, I think that's a fair comment.
I just want to ask you about one example, please. Can I have up on screen INQ 397065? At the time, this is an email from the 18th of March, and just to help you, IPC guidance for domiciliary care was issued the day before, on the 17th, and it said that the Trust should help support independent providers if the independent provider could not get PPE from their usual sources. So that's where we were at, and that was the guidance that came from the department. And here is an email from the Chief Exec of the IHCP to the department. Says, I've been taking calls this evening from a distressed domiciliary care provider who has had no support from the Trust. They have a client presenting with coronavirus symptoms and have been told by the Trust they must provide the care even without the required PPE, and no test will be carried out to determine if it is in fact coronavirus. This is wholly unacceptable. They've doubled up on their normal protective equipment and provided the care rather than leave the client with nothing. The risks associated with this are totally negligent. And then Ms Shepherd goes on to say she's asking for a number of questions She would like a 24/7 response, as coronavirus does not work on an office hours basis. And clearly she's been taking a number of calls, she says, for 10 days now, with the communication not aligned through trust. And you can sense her frustration at being told things that are not delivered. At time of doing this email, I've taken 2 more calls from care home providers in the Southern Trust, having been advised there is no PPE for care homes. It's not a counsel of perfection, Mr. Holland. I hope you will. We can acknowledge that sensibly. But here you have the day before guidance going out to domiciliary care sector saying the trust will help support independent providers, and 24 hours later, clearly still issues with providers getting the support they needed. Do you have any sense of the scale of the problem? Here we are in mid-March where domiciliary care providers were not being supported by the trust. And if so, what did the department do about it?
The first thing I'd say, I obviously can't comment in any detail about an individual example that's been presented. The first thing I would say is that I think it was actually from the 12th of March we first said that trusts needed to support the independent sector with PPE. And in addition to the guidance statements, I phoned each trust chief executive and made it very clear that there should be no organisational boundary in terms of the use of PPE between trusts and the independent sector. And I remember someone saying, are you saying we have to share our PPE? And I said, it's not your PPE. This is a resource for Northern Ireland. So that was the advice, and that message was repeated several times. Now, I think inevitably this was new. Previously, independent providers were responsible for sourcing their own PPE. So you're introducing a new logistics arrangement. So it wasn't going to be smooth from the get-go. And I mean, I know I have a relative who was working as a care assistant in a care home, and she told me of, a car pulling up outside the care home, ringing the bell, and then throwing a box of PPE to the door, and it wasn't a smooth, we need, 100 gowns and 30 masks or whatever. They got a box from the trust, but it did rapidly improve.
And what did the department do to try and aid its improvement?
We reinforced the messaging. We also clarified things like the single point of contact in trusts. I mean, I know Pauline was looking for a point of contact in the department 24/7. We weren't suppliers of PPE. We didn't hold stocks. So the place for them to have a point of contact was within trusts.
Yes.
And that was the way the supply chain worked. We instructed trusts to modify their ordering through BSO PALs to include the care home needs that would be presented to them. So it was BSO PALs, 2 trusts, 2 care homes.
Yep.
That was the chain. So I mean, a single point of contact in the department would have added an extra link in that chain.
Although I think... sorry, go on.
And the other thing I would say is that I mean, the IHCP had the direct phone number of me, my director, and actually the minister. She was able to and did directly phone the minister. What we did as well was in the early days, we were getting reports that saying, trusts aren't giving us what we need or whatever. I think I mentioned before we took the break, we did ask the IHCP, tell us who's having trouble and we'll pursue this.
Yep.
Now, I'm not saying that the list they gave us, those weren't people who didn't have trouble. But when she gave us the list and we started contacting them, they'd say, no, we're getting supplies now. It's working. I think one other thing I'd mention, because I think it's referenced in one of the statements I've seen from the IHCP, was that she referenced we couldn't get FFP3 masks anywhere. And there wasn't any guidance that would have required them to have used. Now, I'm not saying the guidance was right or wrong, but we were only supplying to the guidance. And, I mean, people were scared and they were very, very anxious, so I understand that. But the fact that they couldn't source FFP3 masks isn't an indication that the arrangements weren't working.
Right. Let me pause you there, because the Chief Medical Officer in his witness statement suggests three things that might assist with PPE supply. He says greater resilience of supply lines, including scale up for local manufacture. What, if anything, has the department done to increase the resilience and maybe even do some work in relation to local manufacture?
I'm afraid I couldn't answer that.
He also suggested there should be a greater supply of stock to be held by health and social care trusts. Do you know, as at the time, certainly when you left the department, was there a greater stock being held, and was there any plan in place for the amount of stock that should be held, how long it should be held for?
I know that the, I think it's called the PIP, the pandemic influenza planning, whatever, did allow for a strategic supply of stock. And at one point, I know that I think the minister announced that he had released 30% of that,
yes,
pending more ordering. I don't know, and nor would I have been involved in those discussions. It wouldn't have been part of my responsibility. But just specifically on stock, I do know quite quickly, because there was anxiety in the care homes. They were getting PPE, but they were anxious they were going to run out. And I could understand that, because at the early stages of us telling the trusts to supply them, it was a challenge in terms of supply, and there were a lot of fears about supply. So they wouldn't have been being oversupplied. But at a fairly early opportunity, the minister directed that a buffer stock, a 2 weeks buffer stock, should be issued to care homes, and that happened.
Yeah, I think that came out sometime in mid to late April of 2020.
I mean, that was... I'm sure you remember the stories of planes arriving from China and stuff being useless and all the rest of it. A lot of anxiety in the early days, but we were getting into April, the position hadn't eased, but there was more confidence, and so a buffer stock could be released. And so care homes trusts were instructed to give care homes 2 weeks.
Can I ask you about one other aspect of the department's work, which is the Departments of Health PPE mailbox, which was set up, I think, in late March, when the Chief Nursing Officer and the top management group, as I think it was then called, became aware of reports of concerns about lack of PPE. And the mailbox was set up not as an advisory service, but to forward the queries to the most appropriate either person, sector, department, organisation to respond to them. And it only received 95 queries as at the end of December 2020 across health and social care. Do you know, Mr. Holland, why, on any of you, that seems quite a low number of queries into the department's PPE mailbox?
I would hope that it was a reflection on the fact that the other arrangements that were in place were working well. So we had reconfigured or repurposed the RQIA to provide service support teams.
Yes.
And they were providing advice and support to care homes. And I think it's important, because I think most of the countries did something around repurposing regulators to provide an advice service. But there are differences. I mean, in England, for example, the CQC had a policy for years of having, I think they call them generalist inspectors and specialist inspectors. And the generalist inspectors weren't health and social care professionals. The RQIA was never like that. All of its regulatory staff were either social workers, doctors, nurses, physiotherapists, what have you. So the service support team providing that service were people who could give a high quality of advice, and they would have been providing advice in relation to queries about PPE. In addition, there was the point of contact within trusts, and the PHA were also providing support to the independent sector on PPE. So the helpline was kind of like just to be sure, make sure that with as many arrangements as possible that could address.
You've just mentioned there the SST that was set up, Services Support Team, and I'm going to deal with that topic mainly with the Chief Medical Officer, Mr. Holland, but just from the department's perspective, do you think there is a role in the future for the Services Support Team in the event of a future pandemic?
I'd have to say I think it was, and again, I'm cautious about saying things worked well because, well, anyway, I think it was a positive experience. The service support team became operational very quickly. It provided ongoing support from qualified and experienced people who knew that these were people who would have inspected and regulated this sector, and they were all health and social care professionals, social workers, nurses, physiotherapists, and that was a source of advice directly to providers, and I was pleased to see, I think in the UK Home Care Association's evidence, they noted the experience of the service support team positively in contrast to other arrangements in other countries. So yes, I do think it's something, I mean, in terms of planning for a future pandemic, there has to be a degree of realism. You can't have a mirror system sitting for decades waiting potentially to be used, you know, but you can have plans in place to how you can quickly work up supports, and I think something like the service support team should be incorporated into future planning arrangements.
New topic, please, and visiting, and in particular I'd like to ask you some questions about the care partner scheme, but just to put it in some context, the guidance for care homes on the 17th of March 2020 did not impose a blanket ban, but we are aware that I think certainly about 82% of care homes were restricting visits prior to that date anyway. Come forward to September 2020, and I think there was a move for one face-to-face visit per week by one person. And there was the care partner scheme. I just want to be clear, was the care partner in addition to the one-to-one face visit?
The care partner scheme was intended to be something quite different from the regular visiting arrangements. We were getting a lot of correspondence, and we also would have had engagement with people. As restrictions were lifted for wider society, there was growing frustration, absolutely understandable frustration from families, although it wasn't always straightforward. There were families who didn't want visitors coming in, though, but a growing number of people who did want to visit. And I can't remember exactly the genesis of it, but the proposal for care partners was slightly different to increasing regular visiting, in that it was recognising, and I would have experience of this from my own family with relatives in care homes, that sometimes you'll have a member of your family who plays a particular role, and actually the idea was you could be able to treat that person more like a member of staff. Because, I mean, I can think back to relatives who were in care homes pre-pandemic, and I can think of a relative of mine and another relative, and the relative would have gone in and fed them every day.
Yep.
Would have done sort of some physio with them and stuff like that. And so the care partner scheme was trying to say that where you have needs that pre-pandemic were being met in that way, can we start to bring that back in and treat the person as if they were a member of staff? Because it wouldn't have been a significant additional risk if you put the right arrangements around it. You know, if you're letting staff in, why not let a designated person in who actually would be a support to the care home, because they'd be undertaking some of the burden that the staff normally would have to meet.
Let me pause you there because we're going to just look at a little bit of the guidance in a moment. But the guidance came out on the 23rd of September and it was to be implemented by the 5th of November to give care homes time to make the arrangements, identify the care partner and the like. But prior to the 23rd of September, had there been any engagement with the sector about the practicalities surrounding the care partner scheme, or did that come after the guidance had come out but before it was due to be implemented?
My understanding, and this work was led by the Chief Nursing Officers Group, was both. There was engagement. I know that the IHCP said they hadn't been engaged prior to the announcement, but there had been engagement with people in the sector. And I suppose that reflects the fact that while conversations with the IHCP were important, they were an organisation who represented the business interests of care homes, whereas we had a lot of relationships directly with care homes where if you were looking to discuss practice and develop practice, if we went through the IHCP, they would simply have had to gone to their members to get feedback, whereas we would have just gone directly. I mean, we had very good relationships with certain providers.
Let's just look at the definition of a care partner, please, and have up on screen INQ 256450_30. This is taken, Mr. Holland, from the actual 23rd of September guidance. It says there at paragraph 4.1, care partners are more than visitors. They will have previously played a role in supporting and attending their relatives' physical and mental health and or provided specific support and assistance to ensure that communication or other health and social care needs are met due to a pre-existing condition. Without this input, a resident is likely to experience significant and or continued distress. It's a fairly broad definition there, if I may say, but how was it going to actually help the care homes decide who was or was not a care partner?
I don't know the detail of the discussions as they developed, but I don't think that would be necessarily that difficult because, as I said, this was building on arrangements normally that had been in place prior to the pandemic. You know, before the pandemic, we didn't call them care partners, but it wasn't uncommon for there to be visitors who played a much more active role in the care of someone in a care home beyond a wider range of visitors.
Well, let me put it another way then. From the perspective of the loved one or the relative, how did they prove to the care home that they were a care partner and not just someone who was coming in once a week to see their loved one?
I think that the notion that they would just be coming in once a week, people want to provide care for the people they love. I wasn't aware of a challenge with people putting themselves forward unsuitably for the role, and I'm not sure I understand why anyone would unsuitably put themselves forward for that role.
The care home guidance, the guidance that came out on the 23rd of September said nothing at all about testing arrangements for care partners. Do you know why the guidance didn't say, well, they're not going to bring in testing or we're going to bring it in due course when there's more capacity? Why is the guidance totally silent on whether care partners should or should not be tested before coming into the care home?
I have to be honest, that the detail of this was dealt with by the Chief Nursing Officer. I think that there was some preparatory work before the September announcement. These weren't ideas that just came out of the blue, but they were announced in a draft state. It was acknowledged there was going to be ongoing work to refine and develop them as implementation moved forward.
Okay. As I understand it, it was not underpinned by legislation, the care partner regime, but the expectation was that it would be followed.
Yes.
Minister Swan states that it should be put on a statutory footing. Do you know what the department's view is on whether care partners should be made subject to statutory legislation?
I wouldn't have current awareness of what the department's position on it is, so this is a slightly speculative answer, but I'd offer a few views. I think that both the RQIA standards and the fact that these are contracted services provide some levers that can be used to shape the nature of a service, and that could include care partners. I think that there has been a reluctance on the part of trusts to use the contract with a care home to influence practice. And I think that's been a failing. And if that was something that were more developed, I don't know if you would need to think about a statutory footing for care partners. I was struck very much in talking to trusts that I couldn't find any instance where there had been deficits in service provided by a provider. And I'm not talking about minor deficits, I'm talking about where there have been significant problems which had resulted in a withholding of a payment for a service. Now, that always struck me as strange, because I don't think, in most areas of life, if you pay for something and you don't get what you paid for, sort of withholding future payments is an accepted practice. But there seemed a very strong reluctance, maybe if that was explored. Although, if you take care partners as being part of an expression of Article 8 rights, then maybe it is appropriate for it to go on a statutory footing.
Can I just move on a few weeks in time to the 12th of November? And in theory, this care partner guidance should have been implemented by the week before. And can I have up on screen, please, INQ 256455_3. This is a letter co-written by you and the Chief Nursing Officer. And we can see at the top of the page there that you've annexed a copy of the guidance that had gone out. You said, since that time, we've been engaging with stakeholders, including representatives of families and of care homes, the ICHP, trust staff, including those providing support to care homes, etc. Listen to concerns regarding the implementation of the care partner and to provide a supplementary description around the concept. What was the supplementary description that you provided?
I think it was just more information and more granularity as to how it would work. But I'm not, I can't recollect exactly. We were getting a lot of feedback from families about visiting in general and the care partner concept. Once people became aware of it, they were very interested and wanted to engage in that. And myself and the Chief Nursing Officer held a few virtual meetings with relatives, and they were very emotional and fraught meetings for very obvious reasons, but they were very keen on relaxing and increasing access to visiting generally and the care partner scheme. On the other hand, we had care homes who understandably were nervous because of their experiences earlier on in the pandemic, and particularly if they hadn't experienced it themselves, they will have seen other homes where there had been a significant number of deaths. So I think they were scared. And, in other contexts, we'd given a message out about absolutely minimising the number of people going into a care home as a preventative measure. And now we're trying to relax that arrangement specifically in relation to visiting and the care partner.
Should we take it, though, that if there was need for a supplementary description and work, perhaps that the original guidance wasn't as helpful as might otherwise have been, had there been that stakeholder engagement? Do you think that's a fair criticism, Mr. Holland?
No, I don't. I think that it was always recognised. I mean, this occurred with some other issues where people, I can think going back all the way to the March 17th guidance, where the IHCP were critical of the fact that we'd issued guidance without what they would have considered full consultation. Full consultation normally for a department could stretch anything from 6 to 12 weeks, involve very extensive engagement with a range of stakeholders. I think there were points where it would have been negligent to have withheld what was available at a point in time to wait for full consultation. I think in the case of the care partner scheme, we wanted to give hope to relatives as early as we could to say, look, we're looking at your concerns. We've got some plans, that we're bringing forward. This is what they look like. But those plans weren't fully developed, but I think that's okay. And you then work through the issues with providers as you go.
I think in due course, there was clearly always that tension between reducing footfall, particularly in the autumn of 2020 as numbers began to rise into that winter.
Yeah.
And here you are, potentially, I think it was potentially two people could be named as care partners, plus the face-to-face visitor. So you've got 3 people potentially going into a care home without the professionals that are going in, without the staff going in. Was any thought given to increasing the amount of testing available to the care partners? We know it came in over the Christmas period, where there was 1 test a week for 1 visitor over, I think, about a 3 or 4 week span. But do you know why that wasn't done back in November when the care partner scheme should have been implemented?
I'm assuming, and it is an assumption because I wasn't involved in the detail of the discussion, that as testing capacity became available, it was used more extensively. But that's an assumption on my part.
And just finally on this topic, you say in your statement that by mid-December, 182 care homes had implemented the scheme, and by September 2021, 289 had, which rather begs the question, what about the other 200-odd care homes that hadn't implemented the scheme? What, if anything, did the department do to find out why they hadn't, and maybe to encourage compliance with the scheme?
There were steps taken to encourage compliance with the scheme from it being first announced in the September on a continuous basis. I think that the steps that were taken to encourage compliance started in a very supportive way. It was about trying to explain, reassure, provide more information, answer questions. As more time went by, if you had people who wanted to be care partners and there was still resistance from a care home, we started, and I think it might have been referenced in the letter that you had up a few moments ago, reference to if you're receiving funding, we'll need to consider whether, if you're not complying, and we also, I think, referenced the fact that compliance with visiting guidance, and I can't remember if it was also the care partners, certainly with visiting guidance, might be considered by the regulator when inspecting against the relevant standards about maintaining contact with families. So it was, as far as possible, a softly encouragement, sort of nurturing approach, but there was a little bit of an edge as you went on. As to the answer to the second part of your question, it was always recognised that not all families and maybe not all care homes would require a care partner scheme. Okay. The profile of people living in some care homes is very, very different. We have homes and supported living arrangements and non-nursing homes, for example, where people are there on a respite basis, so it's short term, and indeed normally that's to give a break from the people who are primary carers, so you wouldn't have them there. You also have mental health facilities which would have a different while I'm not saying visiting and relationships aren't important, you wouldn't have the need for support and assistance with direct personal care tasks. So there could be a lot of reasons as to why you would never reach the full 482 number.
Understood. All right. Can I just ask you one other topic on visiting, please? Certainly, the department's position was that necessary healthcare visits should always continue throughout the pandemic. And I think you have seen reference in the Care Homes 10,000 Voices report from September 2020, where 58% of respondents said that their healthcare professionals did meet their needs, but 22% stated healthcare professionals met their needs some of the time, and 20% said they were never met. So 42-ish% of either not met at all or only met some of the time. Was the department aware that there were problems with getting healthcare professionals to pay the necessary visits into care homes? And if so, what did the department do about it?
That would have been a relationship between the trusts and the care homes. The trusts were contractors with the care homes. They were employees of the staff who needed to get access to care homes. We would have been aware because trusts would have flagged up that there were sometimes issues about getting access. We may have intervened directly in cases, although I don't recall it. I think that it was a case of the trusts working with the care homes to ensure that there was access. What we did do was probably increase the capacity to provide in-reach support to care homes to meet healthcare needs. So there would have been in trusts acute care at home services, hospital at home services, enhanced care in the community services, different names, all of which related to the drive over the previous decade probably of trying to shift services that traditionally were provided in hospital into the community. The Chief Nursing Officers Group and the Chief Medical Officers Group had worked basically directing to say there should be a focus from these services during this pandemic on where we know there are concentrations of people with high vulnerability. So they would have been increasing the amount of service of that nature going into care homes. And I think, again, the statements you have from trusts reference the role of trust staff going in to deliver those kinds of services.
New topic, please. And just briefly, some observations from you, please, Mr. Holland, on data. And in your statement, you say that prior to the pandemic, the department did not collect data on care homes. You make references at your paragraph 831 and 832. You said NHS England were recording some social care data in respect of care homes, including number of beds registered, number of beds that are available, vacant beds, the percentage of residents tested for COVID, and the like. And we know that data collection improved over the course of the pandemic, but did Northern Ireland have none of that data as at January or February of 2020? And if not, do you know who did?
Sorry, I'm just looking
And I
at it.
saw 831 onwards in your witness statement.
Yeah. It's maybe a definitional thing, but I apologise if the statement is misleading by saying we didn't have data. We had information about the sector, but the type of information and the timeframes within which it were supplied were not what we needed in the pandemic. And you could make a case and a criticism to say we needed it before the pandemic, and I wouldn't argue with that criticism. But we did have information. So we had a lot of market information, but not in real time. So the market information, we did an annual survey. There was a survey week in relation to domiciliary care, where we took all the information that was available about who was receiving domiciliary care, what for, how many packages, who were providing, and that was the survey week. And that provided information, but it was an annual survey. That's not the same as lifetime data. We also had market information from the analysis provided by commercial consultancies, and that's a source I know NHS England also use. I can think of two consultancies. I think it's Knight Frank, or Frank Knight, I can't remember which, and Lang Buson, who are noted providers of market information. So they'll tell you how many providers there are, profitability, how many business failures there have been, types of bed. But again, it's not real-time information.
So can I pause you there?
Yeah.
Because, I think you said in your statement that there was, at your behest, a design of a template for there was one single return being made. I just want to have a look at it. It's INQ 560995, because clearly there were demands being placed on care home providers and domiciliary care agencies to provide data to lots of people, PHA, RQIA, trusts, and potentially the department. And I think your plan was to have it all in one place. And is this a mock-up of the template that you devised or was devised?
It was, firstly, I can't take credit for this solely. I think there were a number of people who would have been expressing the view, can we streamline this?
Yeah.
The idea was, as you say, to try and ease the burden on care homes because a lot of people were asking them for information. So we did two things. One, we made a lot of financial provision to care homes. We guaranteed their income at one stage, very early in the pandemic, when I know a lot of the talk has been about the sector being flooded. We were concerned about vacancy, so we guaranteed income. But we also, at a point, said we recognise there are administrative burdens associated with data, so we paid a management premium to help people be able to make the returns. But the other thing was trying to simplify the process. And this was our attempt. And I think we were nearly successful entirely, but not entirely, in that the PHA wanted to retain some of their own data collection, but everyone else accepted the single point. And in defence of the PHA, I'm not sure, but I think that might have been in relation to statutory duties because COVID is a registered disease.
Understood.
But we wanted to simplify it. So, and it did change. I think the big leap was being able to move to it being submitted by app.
Yep.
So we got to the point where your returns could be made by an app. There were some additions made to it over time as to information that was being sought. But the idea was that we would start getting real-time data, not the sort of data that you get from a survey once a year.
I understand
but you
that.
get a daily return, I think, before 10:15 in the morning or 10:30.
I think you said in your statement, though, it was supposed to be mandatory, but not everyone completed the form due to either staff absence or they were off caring for sick residents and the like. Do you know if there's any position now where data returns like this are mandatory and indeed monitored for non-compliance?
I don't know what the current position is. I think we did get up to 99% return at one stage, but that was very late on, and there was a law of diminishing returns where, you got big gains, large gains, less gains, and there's a sort of small bit at the end, and we got to 99%. I don't know what the current position is, but I think, again, it's one of the lessons for the system about the care sector. I would say one of the biggest failings pre-pandemic, and I would like to say it's not a failing now, but quite often the health sector views the care sector as being something that's there to support its effective functioning, and that's wrong. Certainly if you have a dysfunctional care sector, it's going to add to burdens on the health sector and potentially collapse, theoretically, the health sector. But it should be seen as something that's important in its own right. People live there. Many people spend their last days there. So it shouldn't just be viewed in terms of how it supports discharge or whatever. It needs to be something in its own right. Now, in the healthcare sector, on any given morning in the department, with a few phone calls, I suspect that you could find out how many ICU beds were available, how many were occupied. You might know something about them. You would maybe know about what the staffing pressures were. Now, certainly going into the pandemic, we had nothing like that. No. Now, partly it's private sector. There were 482 homes, 300 domiciliary care providers. We're not talking about a single unified system. This had been outsourced in effect, and that made it complex. But certainly in the pandemic, it became really important that we knew day to day how the system was doing, and we didn't know that before, and I don't know what the current position is.
There's other people I suspect I can ask about that. Just finally from me, please, Mr. Holland. I'm not going to ask you about the RLIs and all of the other work done by the department, but there is one aspect of Minister Swan's evidence that I'd like the department's views on. He recommended a central registry of unpaid carers to be maintained either centrally by the department or at trust level. He wasn't sure which might be more practical. But what's the department's view on, is that necessary? And if so, how would it help in the event of a future pandemic?
I can't give you a current answer to whether the department feels it's necessary or not. But what I would say is that it is challenging to have a statutory register, but there were deficits in the fact that we didn't have a comprehensive register. We were able to identify people who were in receipt of a service, but not all unpaid carers are. We were able to identify people who were in receipt of direct payments, but not all unpaid carers are. And we were also able to identify people who were in receipt of independent living fund payments and thalidomide grant payments. But that's a much smaller number than people who, who are carers and not necessarily in receipt of a service, but who you might want to communicate with, or you might want to reach out to at a time like this. So I can see where Robin's coming from, and I can understand why he's asking it. Now, I don't think you could force carers to put their names on the register they don't want when they don't want to. But I suspect that it is an area where, with focus, we could improve our knowledge and ability to communicate with the sector. I mean,
can I ask you this then? Because clearly you're no longer in the department, but would it have helped you in your role as chief social worker had there been such an unpaid carers register during the pandemic?
There are some things it would have helped with, but I wouldn't overstate it. So resources and services were already significantly under pressure, and we were already thresholding services. So simply having the identification of unpaid carers wouldn't necessarily have added to us being able to provide them with lots of services. We wouldn't have been able to. But it would have meant we would have had a channel of communication with them, and that would have meant things ranging from providing them with directly, when we published advice, but directly providing them, maybe through an email link or whatever, advice on shielding, isolation, maintaining your own well-being, access to other supports. One example, and I know that you're aware of this, we made available a carer's recognition card.
Yes.
So people could access protected shopping time. If the police stopped them during lockdown, they could say, they could produce this card and the police would accept it. Now, I don't think we were very strict on issuing those, to be honest. I think more or less anyone who asked for one got one, but it's still at its height reached 42,000. The estimate is there are 220,000 people. Another area, I think, would have been advice on IPC and infection prevention control. Now, we did promote that advice very strongly. There was a web-based, the one I mentioned earlier, provided by NISC, was deemed suitable for family carers to use to improve their practice in relation to infection prevention control. But you're sticking things out through social media, and we did put a leaflet drop to everyone. But that's not the same as maybe people knowing there was a portal they could go to for updated advice, where you could directly email them if you wanted to with information. So, there'd be benefits, but I wouldn't overstate them. It wouldn't lead to loads of new services being available.
No. Understood. Thank you very much. Mr. Holland, that's all the questions I have for you. My lady, I think there are some core participant questions.
Thank you, Ms. Carey. Ms. Campbell, who's just over there.
Thank you, Milady. And Mr. Holland, you may know I represent the Northern Ireland COVID bereaved Families for Justice, and we have questions across three topics, revisiting, in fact, some of the evidence that you have already given this morning with the assistance of Ms. Carey. I want to focus, please, first on a correspondence that came to you and the Chief Nursing Officer from the IHCP on the 16th of November 2020. I won't put it on screen, but you'll immediately notice it's just a number of days after the letter that we've looked at recently from you and this Chief Nursing Officer in relation to care partner guidance and the implementation of care partner guidance. And the IHCP write to you that they had provided constructive feedback at the end of October 2020 on the documents issued regarding the care partner role, and has offered to engage fully on, and I emphasise, shaping the concept of that care partner role. And they observed that they have yet received no response or feedback to their questions, and instead there appears to be a delay in meeting to discuss the matter or to develop a supplementary description of the care partner role. with a shift from the Department of Health to the Public Health Agency to take the lead. So we're 16th of November 2020, and this is from the IHCP. And you've observed in your evidence that, of course, the IHCP represent the business interests of the independent care sector, and that's correct. But it's the business interests of some 50% of the independent care sector and well in excess of 200 care homes, both nursing and residential. You'll acknowledge that, is that right? Mm-hmm. And I'm afraid I'll have to ask for...
Yes.
Thank you. It's just for the purposes of the transcript. And you'll also recognise that behind those figures are many hundreds of residents and many thousands of family members being impacted by potential failures to implement care partner guidance.
Yes.
You understand that?
Yes.
So the question really on behalf of the Northern Ireland COVID bereaved is this. Here we are on the 16th of November 2020, almost 2 months after the guidance was issued. Why is it that the representatives of 50% of the independent care sector appear to believe that the care partner role was as yet a concept and one that could be shaped or given a supplementary description?
Again, I have to caveat this by saying that the lead role in developing this work was done by the Chief Nursing Officer in our group. But I do know that both prior to the announcement in September and certainly on an ongoing basis from September, there was ongoing engagement with actual providers in developing the concept. The IHCP is one person and maybe some administrative staff, and the one person is not someone who has experience of running care services. And that doesn't mean they're not an important voice, and on some instances they are absolutely the right voice. But if you're looking to engage, and we found this around a number of areas, if we were looking to engage on a practice issue, that sometimes if you went to the IHPC, you were adding a layer into the chain that caused delay, because they in themselves were not experts in this. So they were going to members and then coming back to you. We had a lot of links with a number of organisations, both in the IHCP and not in the IHPC. And those contacts would have been used particularly around some practical issues. So it would have been more appropriate for the nursing team to engage directly with care homes than with a representative organisation, which in itself was not, and had limited capacity. I mean, at one stage, I'm fairly certain to say the IHPC approached us for funding to increase their capacity because they said they had limited capacity to engage with us. And that was something that considered, and we didn't provide funding to them at that point, but we would have engaged directly with providers.
See, there are concerns, and there remain concerns on the part of the bereaved, many of whom you will know either engaged with the development of the guidance or were desperate to see it implemented at this point in November 2020, that the department was insufficiently clear or robust with the sector, and that might well include the sector representatives, as to the expectations that had existed since we know the 23rd of September 2020, that every effort should be made to implement the guidance. Do you recognise the legitimacy of those concerns?
I recognise that there was a tension between encouraging and supporting and providing advice and information to care homes to enable them to be confident enough to engage with the care partner scheme, and reluctance on the part of some providers, which as time went on became less reasonable, given the understandable fears that were there. I think I indicated earlier that we had a graduated approach in that as we rolled out, and there was still some resistance from a diminishing number of providers, we started to reference that we would use regulatory standards and potentially contracting to encourage more firmly participation. Whether we got that balance right or not, I can't judge, but I do know that it was a risk if we were to alienate people, and our preferred choice was try, mainly carrot, a little bit of stick, but mainly carrot, If that was a misjudgment, it was one, but I don't know if it was.
Well, you, in your evidence, with the assistance of Miss Carey, talked about an approach of a softly nurturing approach in
Yeah.
the first instance. But ultimately, you had to address this impasse in part at a business level, because in your statement you indicate that on the 16th of December 2020, recognising the concerns felt by many care homes about visiting and care partner arrangements, the department announced further support, and I think that included financial support to be available to all care home providers in Northern Ireland to facilitate visiting in line with the guidance, particularly over the festive season. Now, you talked about getting the balance right. Really, if we might focus on how quickly measures were taken at this particularly stressful time for families, why did it take until the 16th of December, bearing in mind the 23rd of September announcement of the care partner guidance in particular, to announce a package that might be capable of achieving some resolution?
I'm fairly certain financial assistance to support visiting predated that by quite a significant time.
Well, we can look at that through your evidence and the evidence of others. Moving on then to reporting of COVID outbreaks, and it's a fairly discrete question. You've been asked a number of questions in relation to domiciliary care, because we know how many people in Northern Ireland rely on it and how many families value it. In your statement, you indicate that there are over 21,000 individuals in Northern Ireland in receipt of domiciliary care, of which nearly 9,000 required 6 or more visits and 10 or more contact hours per week. So that's a lot of people going in and out of people's homes on a very regular basis. And yet we know that there's no statutory requirement for domiciliary care agencies to report COVID outbreaks to the RQIA or indeed anywhere else. And no legislative or regulatory amendments were made at any point to impose such a duty. Do you accept the concerns of the bereaved that relying on domiciliary care agencies to self-report, and we know it became through a voluntary app, particularly when those individuals and agencies were operating under significant time and financial constraints, and you've told us some of that this morning, do you accept that that was neither an adequate nor a robust mechanism to ensure proper monitoring and oversight of COVID outbreaks in domiciliary care?
I'm not absolutely sure, but the emergency legislation made COVID a notifiable disease.
Yes.
And I'm not sure the extent of which, that wouldn't have discriminated against. It was a notifiable disease. The app was separate to that, and that's probably why the PHA wanted to maintain the separate reporting on COVID from the app. I don't think that the app was intended to be the main route by which public health surveillance would be notified through for outbreaks of COVID.
Particularly in relation to domiciliary care?
I'm just saying I don't think that would be the case. There are public health requirements about notifying a notifiable disease. The app wasn't replacing those. The app was about us collecting information about circumstances. I stand to be corrected on this. It's not an area of expertise, but I don't think that you can conflate the request for returns through an app with statutory requirements in relation to a notifiable disease. It's not an area of my expertise.
Well, that's fair, and in fact we've already touched on it through the RQIA as well, so I should perhaps leave it at that. Finally, testing in care homes, and particularly focusing on the period from August 2020. You indicate at paragraph 505 of your statement that a regular programme of PCR testing commenced on the 3rd of August, so almost 5 years ago, 2020, with asymptomatic staff to be tested every 2 weeks and residents were to be tested every 4 weeks. And again, to revisit some of the concerns that the IHCP raised with you, when they brought the views of care homes about the practical impact of that decision, which they again complained was made without consultation with them. I don't expect you to remember the specific examples, Mr. Holland, but I imagine you'll remember some of the sentiment. One care home provider wrote, "I'd be keen to hear other providers' thoughts on the department passing over complete responsibility for administering, ordering, testing, data collection, regular COVID-19 testing for staff and residents to the care home providers. I'm also keen to hear opinions about the timescale for implementation of the 3rd of August. My opinion," writes the author, "is unprintable." And within the same correspondence, there were further similar concerns being raised. Is this an example of the department, again, failing to sufficiently engage with the sector when in August 2020 it made significant changes to the testing regime?
No, I don't believe it is. And indeed, the statement that you've just quoted doesn't reflect the reality of the situation. There was significant support being provided in relation to testing, both direct support and financial support to facilitate testing. And it was a very, very significant level of support. Now, I understand that people's individual experience at a time of pressure, when they're scared, when things are very difficult, can lead them to represent things in a certain way, but that statement wouldn't be an accurate description of the situation.
Thank you. Those are all my questions.
Thank you very much indeed, Ms Campbell. That completes the questions that we have for you, Mr Holland. I do understand how distressing it can be to have to relive those very difficult times. So thank you very much for the help that you've given to the inquiry. I don't know how many people were involved in preparing your statement, but thank you to everybody who helped with that, and thank you for coming here today.
Thank you very much, my lady.
Thank you. Very well, I shall return at 2:15.